This is Chris. I'm one of the chief fellows this year. I think everyone on is uh, so I'd like to introduce Dr. Megan Kamath, who is happy to have for ground rounds today. So Dr. Kamath is one of our advanced heart failure specialist transplant cardiologists. She also specializes in cardio OB and complications associated with that. Also with cardio oncology also. So thank you, Dr. Kamath, for giving our ground rounds today, and I'll hand it over to you.
Thank you so much, Chris, for that lovely introduction. I think I know most of you from either my time in training or now as an attending here. So thank you for the opportunity to speak today. I'm going to be talking about pregnancy and the advanced heart failure population, two areas that I have either become more familiar with during my time as a trainee or as attending. And I've seen more and more patients over the last years with the intersection of these two conditions. So I wanted to highlight some of the more recent updates, what limited data that we do have, talk about that a little bit, and talk about really where we're headed as well. So here's an outline of today's talk. I'm going to give a background for why this topic is really important. I'm going to highlight cardiobstetrics, which is a growing field. I'm going to highlight some of the hemodynamic changes of pregnancy that will be important for you to be aware of. We'll go through risk stratification schema, and then we'll focus on pregnancy in the advanced heart failure population, specifically attention to peripartum cardiomyopathy, mechanical circulatory support, pregnancy post-heart transplant, and then we'll finish up with peripartum considerations for labor and delivery, long-term cardiovascular care considerations, and some future directions for research, and a little bit about our UCLA cardio-obstetrics program as well. So why is it really important to know about cardiovascular disease with respect to pregnancy? Well, in the US, cardiovascular disease is now the leading cause of death during pregnancy and the postpartum period, with many patients having advancing maternal age and delaying childbearing. Underlying medical conditions like hypertension, diabetes, and hypercholesterolemia have become more common, and that's also increased the incidence of acquired heart disease complicating a pregnancy. This is data from the NIH, which is quite jarring. If you look at the left side of your screen, you can see that the United States has the highest maternal mortality ratio of several developed countries. And you can see on the left there, the US, and then looking at Canada, Finland, Japan, and Qatar. And on the right side of your screen, you can see that there are significant racial disparities for maternal mortality in the United States as well, which is equally jarring. Blacks and American Indians and Alaskan Natives are at the highest risk for maternal mortality in the United States. And you can see that by a significant amount there on the right side of your screen. So the NIH has really invested a lot of money into funding research in this arena to not only identify risk factors, explore disparities, develop and test new treatments to help improve maternal health and care. But despite spending $224 million by the 2020 numbers, in the US, 700 deaths are reported and 50,000 patients are at risk for severe disease from problems in and after pregnancy. And that's really just not acceptable. So there's more to be done. Maternal mortality in the US, as I mentioned, continues to rise. It continues to rise by race across all races. As you can see here, this is data from 2018 to 2020 across all races. Maternal mortality has continued to increase. and also across all age groups. You can see that the largest increases have been in the 40 and over category on the right side of your screen, but there have been increases in maternal mortality in the under 25 and the 25 to 39-year-old age group as well. So this is really significant, and this needs to be a call to action. Traditionally, when we think about cardiovascular risk, we've talked about things like diabetes, tobacco use, obesity, physical inactivity, hypertension, and dyslipidemia. But when we think about the women's cardiovascular health, we need to think about other non-traditional risk factors as well. Things like a preterm delivery, hypertensive disorder of pregnancy, gestational diabetes, autoimmune diseases, even some treatments for breast cancer and depression as well. When we talk about cardiovascular risk in women, we often hear a word in the cardioobstetrics world called the reproductive continuum. And it really refers to 6 critical time periods that are often referenced, that are crucial in optimizing women's health and optimizing outcomes for patients. Those time periods are listed on the left side of your screen, but I'm going to go through them one by one. First being the preconception time period, second being the pregnancy time period, third being labor and delivery, fourth being immediately postpartum, fifth being what's called the 4th trimester, or really the first 3 months after delivery, and sixth being long-term implications of the complications that have been experienced during any of those previous 5 critical time periods. And what is important about this is that during each stage or at each critical time period, we as healthcare professionals and providers have certain steps that we can take to improve our patient's outcome. So for example, during the preconception period, talking about contraceptive advice, optimizing the patient's medical status prior to pregnancy, adjusting medications to make sure that they're not teratogenic, and performing a comprehensive risk assessment. So things like that can make a very, very large difference in the patient's outcome overall. This highlights the need for a cardioobstetrics team. And really, what does that mean? It refers to a multidisciplinary team of clinicians who are focused on the care of these vulnerable patients from preconception through the postpartum period and beyond. Some of the key team members that we have on our cardioobstetrics team include cardiologists and cardiac subspecialists, obstetricians, maternal fetal medicine specialists, cardiac anesthesiologists, cardiothoracic surgeons, pediatric cardiologists and neonatologists. Sometimes we even need to have our pulmonary hypertension specialists involved, certainly primary MDs, as well as allied health professionals, cardiovascular team members, mental health specialists, pharmacists, and even geneticists as well. So this really highlights the importance of having a village surrounding these patients to be able to optimize patients' experiences and outcomes as well. So why is it important to think about risk and assess optimization of care preconception? Because pregnancy is often called nature's stress test on the body due to the number of physiologic changes that occur during this time period. And the cardiovascular changes of pregnancy occur quite early on in the first trimester. As you can see on the graphic on the left side of your screen, the cardiovascular changes of pregnancy begin as early as 4 to 6 weeks of gestation, which is sometimes before a woman even knows that she is pregnant. Some of the earliest changes that we see include vasodilation of the systemic vasculature in the maternal kidneys, as well as a substantial decrease in the peripheral vascular resistance. Importantly as well, though, by 2 weeks after delivery, the maternal hemodynamics have largely returned to non-pregnant levels. So the takeaways here are that changes happen fast, changes are sustained during the gestational period, but by 2 weeks after delivery, hemodynamics have largely returned to non-pregnant levels. So that's why we have to be all the more vigilant during this time period as well. So a little more about each trimester here. This is from the Journal of the American College of Cardiology, paper published in 2021, where, as I mentioned before, systemic vasodilation begins as early as 4 to 6 weeks of gestation, with a decrease in PVR that's sustained through the middle of the second trimester. They estimate that drop at about 35 to 40% at its nadir. During the second trimester, one of the largest changes that occurs is in the cardiac output, which continues to rise in a nonlinear fashion. In the third trimester, the heart rate, which has risen throughout gestation, usually peaks in late third trimester at above 10 to 15 beats per minute above non-pregnant values. So as I showed you, the hemodynamic changes of pregnancy make it all the more important that we risk stratify our patients and counsel them with shared decision-making, not only prior to pregnancy, but early in the pregnancy, depending on each patient's particular clinical scenario. So what are some of the things that are important to consider? Well, there are different risk stratification schema, which I'm going to get into, and this slide kind of highlights the 3 main schema that we use. But things that we need to be aware of are the patient history. Have they had cardiac events prior to pregnancy? What is their baseline NYHA functional class? Have they had any interventions prior to pregnancy as well from a cardiac perspective? What does their physical exam look like? Do they have specific lesions like a mechanical valve? Do they have coronary artery disease, or do they have a high-risk aortopathy, for example? What kind of imaging have they had? Do they have evidence of systemic ventricular dysfunction or other high-risk lesions? And are they able to access care? Do they have a history of non-compliance? Have they been through fertility therapy? Have they had other types of cardiac testing, or are they on medications for other comorbidities? Or do they have any other rare or unstudied cardiac conditions? These are all things that we have to be thinking about when we're seeing these patients and trying to stratify them with respect to risk. The most common risk stratification schema that you will see is the WHO pregnancy risk classification. And that divides patients into 4 categories: class 1, class 2, class 3, or 4, with class 1 being really no detectable increased risk of maternal mortality, and either no or a mild increase in maternal morbidity risk, with class 4 being that pregnancy is contraindicated, meaning there's an extremely high risk of maternal morbidity, severe maternal morbidity, or maternal mortality, and pregnancy is contraindicated. If you have a patient that falls into that category, if pregnancy occurs, then termination should be considered. I like the way that it's described in this scenario, because it kind of gives you it in red there, big stop sign, you want to think about that. Some of the conditions that we might consider in that category would be PAH, pulmonary arterial hypertension, severe systemic ventricular dysfunction with an EF of less than 30%, moderate or more systemic RV dysfunction, severe mitral or symptomatic aortic stenosis, severe aortic dilation, vascular Ehlers-Danlos or severe coarcted or recoarcted, or a Fontan with any complications. And so these are things where pregnancy is not recommended. And if pregnancy is desired to continue, shared decision making should certainly happen, and expert center involvement needs to be of the utmost importance. On the right side of your screen, you'll see the Zahara risk stratification schema, which was really derived from patients that have congenital heart disease as well. And I'll show that here as well. This was from 2010, looking at predictors of pregnancy complications in women with congenital heart disease. So this is commonly used in that population. Going into a little more detail about the risk prediction index called the Cardiac Disease and Pregnancy Study, or the CAR-PREG, we look at 10 different predictors, which you can see on the right side of your screen there. And each predictor is assigned a weighted point score. Depending on the predictor or the number of predictors that a patient may have, the risk score sum is the total risk score that's derived. So if a patient has a history, for example, of prior cardiac events, they'll get 3 points. And then if they also have ventricular dysfunction, they'll get another 2 points. And on the left side of your screen, you can see the predicted in the light blue and the observed frequency of primary cardiac events in the sort of medium blue color there, and the validation group in the dark blue on the left side of your screen. What are the most common complications that we see in women with heart disease during pregnancy? Antepartum, by far and away, the largest number of events are arrhythmia related. You can see that in the blue on the left side of your screen there. Whereas late antepartum and going into the postpartum period, most of the cardiac events that occur, complications that occur, have been often pulmonary edema related, as you can see in the red side of your screen. So this paper was actually co-authored by Dr. Vasegi, one of our own UCLA electrophysiologists, and highlights the importance of addressing arrhythmias in pregnancy. And this came out in JACC EP in 2022. I think a couple of the important takeaways from the article are on the right side of your screen there, where it highlights common SVTs. AVNRT or AVRT are the most common that you see. Also atrial fibrillation seen as well. And then highlights the importance of being prepared for a cardiac arrest. While uncommon in the maternal population, it's important to know that the resuscitation and CPR protocol is really unchanged. Important to note that administration of drugs during this resuscitation period should be above the diaphragm to facilitate resuscitation. And urgent preparation for early cesarean delivery to improve maternal and fetal survival is also of the utmost importance. Most of the literature says that if the uterine size is greater than 20 weeks, then preparation for early cesarean delivery during this type of event is really essential and crucial to trying to ensure survival for both the mother and the fetus. Importantly, no medication should be withheld out of concerns for fetal teratogenicity. And then drug doses and defibrillation protocols remain unchanged as well. As far as device management goes, if a patient does have a device in place, important to think about that management during labor and delivery, as well as continuing fetal and cardiac monitoring during that time period as well. So talking a little bit more about antiarrhythmic drugs in pregnancy, I put this in mainly for reference, where you can see on the left side of your screen that they're on the green and in the yellow. There are many antiarrhythmic drugs that have been studied or have extensive data or moderately safe in the yellow there, data to use in pregnancy. And as you can see on the to the right of the drug name, you can see the lactation symbol there. Quite a few of these drugs have been studied in lactation as well, although certainly it needs to be a discussion between patient, providers, team members to figure out what's the best way to move forward with taking care of these issues, both antepartum and then going into the postpartum period as well. On the right side of your screen, you can see the commonly used antiarrhythmic medications, the von Williams class in the middle, and the potential fetal adverse effects that have been documented. But however, notably, there are several medications, as you can see, that have really no adequate data or limited data or really only animal study data as well. So definitely a shared decision-making approach becomes very important in these scenarios. With risk stratification and treatment of underlying conditions, we have been able to improve outcomes for women with heart disease and safely get them through a pregnancy. As you can see on your screen on the bar graph here, looking at the cohort between 1994 and the year 2000 in blue, and then the cohort from 2001 to 2014 in red, certainly there has been improvement over time in the outcomes for these women. So now let's talk a little bit about peripartum cardiomyopathy and why this is important. So peripartum cardiomyopathy has traditionally been defined as a non-ischemic cardiomyopathy with a reduced EF of less than 45% that commonly presents in the first few months postpartum or towards the end of pregnancy. Some of the risk factors that have been described are African American race, preeclampsia, hypertension, multigestational pregnancies, and a maternal age greater than 30 years. What makes this challenging to diagnose is that some of the symptoms of peripartum cardiomyopathy can be confused with common symptoms of normal pregnancy. And furthermore, there can be overlap with other types of cardiomyopathy symptoms as well. And we'll get into that in the subsequent slides. So the pathophysiology of peripartum cardiomyopathy is still something that is under a lot of research and debate. Most recently, there has been a thought that two potentially vasculotoxic hormones of late gestation, SFLT1 and prolactin, can trigger peripartum cardiomyopathy in sensitized hosts. And the thought is that maybe these two hormones can explain the connection between patients having preeclampsia, multiple gestations, and then developing peripartum cardiomyopathy. And then on the left side of your screen there, you can see the incidence of peripartum cardiomyopathy goes up dramatically in the first 1 to 4 weeks postpartum compared to the antepartum time period and then the later postpartum time period as well. So important things to remember: peripartum heart failure is a non-familial cardiomyopathy, idiopathic in nature, occurring to towards the end of pregnancy or the months following delivery. Importantly, where no other cause of heart failure is found. Other recent research has shown that in about 15 to 20% of patients that have been found to have peripartum cardiomyopathy, patients have been found to carry mutations in genes like titin, beta-myosin heavy chain, myosin binding protein, lamin A, and SCN5A as well. So there's ongoing research into a possible genetic predisposition as well. And perhaps a connection between peripartum, dilated, and familial cardiomyopathy may be there as well. That's just not very well defined at this point. Again, I highlight that symptoms may also be missed in the last trimester of pregnancy because they're often seen in normal pregnancies as well. So things like dyspnea or edema in the lower extremities can be seen in a normal pregnancy, but can also be seen in patients who are developing peripartum cardiomyopathy as well. On the right side of your screen here, you can see this is from the European Journal of Heart Failure, some of the biomarkers that have been or are being looked into with respect to peripartum cardiomyopathy. But many of these are not routinely checked. Probably of the ones that are listed there, the one that we see most commonly checked would be the proBNP. So when we think about peripartum cardiomyopathy, we think about management during pregnancy, at delivery, and after pregnancy as well. During pregnancy, the management is largely symptom-based and with a specific attention to improving patients' cardiac function. It's important to consider mechanical circulatory support for severe heart failure or cardiogenic shock as needed, and to think about that early as well, and to consider early delivery if the patient is unstable as well. Thinking about delivery, planning ahead with the cardiac obstetrics team is really important. And if the patient is unstable, considering hemodynamic monitoring and optimization, and really watching in that immediate postpartum time period for fluid overload due to the significant fluid shifts that occur after delivery in the early postpartum period. After pregnancy, close surveillance is really important with respect to heart failure management, considering anticoagulation, and then appropriate device therapy as well, depending on the severity of LV dysfunction. And probably one of the other most important things that should occur is a discussion regarding contraception as well. In studies that have been done so far on peripartum cardiomyopathy, those patients who have been shown to do more poorly are those with a lower LVEF, a more dilated LV, a delayed diagnosis, and then there has been a racial disparity that's been shown with African American patients as well having a worse outcome. The other thing that I think is important to highlight is that at this particular point in time, after recovery of LV function, the optimal duration of medication treatment for peripartum cardiomyopathy still remains unknown. Recommendations have continued to be for close surveillance after recovery of LV function, and then in the case of stopping or weaning medications, doing so gradually with close observation and monitoring as well. So as I mentioned, diagnosis of exclusion, you have to consider the differential diagnosis for heart failure in pregnancy prior to labeling a patient peripartum cardiomyopathy. The reported incidence in the US has ranged anywhere from 1 in 1,000 to 1 in 4,000 patients, but this may be increasing as well due to increased recognition of disease, rise in maternal age, and contemporary fertility techniques as well. So the true incidence still remains unknown. As I mentioned, outcomes are variable. Women may have complete recovery or persistent myocardial dysfunction and heart failure, or they may have rapid deterioration leading to urgent need for temporary or durable mechanical circulatory support and even consideration for cardiac transplant. So I put this graphic in to talk about what are some of the other differentials that we need to consider before labeling a patient with peripartum cardiomyopathy. So thinking about things from Takotsubo to a familial cardiomyopathy, to hypertrophic cardiomyopathy, to a myocarditis, to an arrhythmogenic right ventricular cardiomyopathy, to hypertensive heart disease, other systemic reasons for cardiomyopathy as well. Those are just a few of the different types of cardiomyopathies that we need to be thinking of prior to labeling somebody with a diagnosis of peripartum cardiomyopathy. And there may be overlap too. That's an important piece. So when we think about peripartum cardiomyopathy, we think about a spectrum from mild to moderate to severe. Mild being, your hemodynamically stable patient, to severe being your cardiogenic shock patient that you're dealing with in the CCU or in the CTICU with hemodynamic instability and respiratory insufficiency. And depending on where the patient falls on this spectrum, there are certainly different interventions that can be considered. Certainly for the mild cases, up-titration of goal-directed medical therapy, diuretics for volume management, consideration of bromocriptine. For the moderate category, diuretics, antihypertensives, supplemental oxygen or non-invasive ventilation if needed, consideration of bromocriptine, but for a longer duration. And then additionally, the oral GDMT as well. And then for the severe category, the intravenous diuretics, inotropes, pressor support if needed, invasive ventilation, early consideration of mechanical circulatory support, whether that's ECMO, balloon pump, Impella, consideration for evaluation for cardiac transplant as well. So this schematic came from the European Society of Cardiology. They came out with guidelines in 2018 for the management of cardiovascular disease during pregnancy. Key things are to assess the initial heart failure severity, confirm the diagnosis, and then to really try to optimize the patient from this shock perspective, optimizing preload, oxygenation, adding inotropes or vasopressors as needed, considering urgent delivery, and considering early initiation of mechanical circulatory support is really important. So then you can get to that stage here on the bottom left side of your screen where you can think, is the patient either going to be able to recover? Is there a chance of that? Or do we need to pursue cardiac transplantation further as well? Again, the importance of a multidisciplinary team and shared decision-making is really important. This takes into account the importance of the cardiologist, the obstetrician, the neonatologist, anesthesiologist, cardiac surgeon, as well as the status and prognosis of both the mother and the fetus as well, when determining the way to proceed for these very, very complex high-risk patients. Switching gears just a little bit to focus a little bit more on pharmacologic considerations, because as I mentioned before, the one of the mainstays for that mild peripartum cardiomyopathy group and even the moderate peripartum cardiomyopathy group is making sure that we up-titrate their goal-directed medical therapy in a timely fashion. It's also really important to remember some of the changes that occur during pregnancy with respect to absorption, bowel motility, gastric pH changes, ventilation changes, secretion, reabsorption, renal clearance changes as well. Those can be really important in making decisions regarding your pharmacotherapy adjustments that you're going to be pursuing for these patients. So just keeping that in mind that these changes do occur during the gestational period and keeping that in mind when making those dosing adjustments as well. When we look at the pharmacologic treatment for peripartum cardiomyopathy, as I mentioned, the mainstays during pregnancy, loop diuretics, beta blockers, hydralazine nitrates, and digoxin. During pregnancy, ACE-ARB, aldosterone antagonists, sacubitril valsartan, and ivabradine really not able to be used During lactation, however, you can consider adding in the enalapril or captopril or spironolactone as well. With the ARNI, there's really no information in humans with respect to lactation. The animal studies have shown that sacubitril valsartan is present in rat milk, as well as ivabradine has been shown in animal studies to be present in rat milk, but no information in the human population. So, as I mentioned, one of the biggest questions that remains with peripartum cardiomyopathy is how long to continue the drugs when a patient has had complete and sustained recovery of LV structure and function. This data from the European Society of Cardiology suggests a careful, controlled, slow wean over a period of at least 18 months, and with close monitoring echocardiographically every 6-month intervals. So there is no guideline at this particular point in time, but certainly that seems to be the most documented recommendation is if a patient does have sustained recovery of LV function, then it is possible to continue to try to slowly wean these medications, but in a very, very controlled fashion as well. I put this slide in to just highlight that when you are considering any medication in pregnancy or in the postpartum time period, highlighting these references can be really helpful. In the absence of clinical safety data, there are other supplementary data that can be considered to look at preclinical safety data, and decision-making based on just the former FDA categories alone is not recommended as well. So I wanted to highlight a little bit about bromocriptine since I mentioned it before as being something that has been recommended to consider. The data on bromocriptine is really limited and really from several remote areas or very small populations. So one of the first studies that came out about bromocriptine came out from Burkina Faso in 2017. It looked at 96 women who received 4 weeks of bromocriptine therapy. And while there was an improvement in EF at 2 weeks, and the improvement was sustained at 3, 6, and 12 months, as you can see, it was just a very small study from a very remote area with limited broader geographic applicability. So there was a German trial that was done the year after or so, which looked at giving patients 1 week of bromocriptine versus 8 weeks of bromocriptine and looked at endpoints of change in EF, heart failure hospitalizations, need for transplant or LVAD, and death. Again, it was a very small population that was looked at. And while there was EF improvement in both groups and a non-significant trend towards full recovery in the group that was given bromocriptine for 8 weeks, there is still not enough information to make it a guideline-based recommendation at this point. Importantly, though, in the group that they looked at, nobody needed to have a transplant, LVAD, or death, or nobody died, but it's still something that is in its infancy of being studied, so something to consider, but certainly may not be super helpful in your patient that is already in that severe peripartum cardiomyopathy category in the cardiogenic shock stage. So briefly, a little bit about subsequent pregnancy considerations. Certainly shared decision-making is key, considering risk factors and events up till this point. Noting that the risk of fetal complications is extremely high if the LVEF remains less than 50%. And this is data from Jack in 2014 that shows the extremely high incidence of fetal prematurity, and as well as therapeutic abortion if the patient's LVEF is less than 50%, as you can see here in this salmon coral color. If a patient does decide with their care team that they would like to proceed with a subsequent pregnancy with the LVEF having returned to normal postpartum, it is really, really important to have close clinical assessment with imaging, with echocardiogram and lab work, including a BNP, to be performed at regular intervals as well, and with any change or development of concerning symptoms too. So assessing prior to conception, assessing at each of the end of the first trimester and second trimester, before delivery, after delivery, prior to discharge, and then within 1 month after delivery too. That will be really, really important. When we think about postpartum care for patients with peripartum cardiomyopathy, some of the things that we can do to improve patient outcomes include early postpartum visits, trying to coordinate them with the OB and the MFM as well from a cardiac perspective. Adjusting medications in a timely, appropriate fashion. Counseling regarding contraception and future pregnancy risk, that should happen early. Depression screenings, and then modification of other cardiovascular risk factors as well. Some of the things that have been shown to improve patient outcomes for those patients who have poor functional class, consideration of cardiac rehab. For those patients with cardiomyopathy and worsening heart failure, considering advanced interventions at an earlier stage, considering anticoagulation for those folks who have an LVEF less than 35%. For valvular regurgitation lesions, thinking about the need for intervention early on. For arrhythmias, similarly, thinking about ablation or device therapy. And then certainly one of the most important keys is postpartum blood pressure management and making sure that that risk is also mitigated as well. All right, so now we'll switch gears and talk a little bit about mechanical circulatory support in pregnancy. Again, most of this data is case report or case series based, very limited, but I'll highlight what has been shown so far. So this study looked at the outcome of patients with peripartum cardiomyopathy and consecutive implantation of the left ventricular assist device. This came out of Europe and looked at the patients that were registered as part of the European Registry for Patients with Mechanical Circulatory Support called EuroMax. So this was data from between the dates of May 2011 and September 2018. There were 16 patients who were identified with peripartum cardiomyopathy and consecutive LVAD implantation. Notably, these were very, very young patients. The age average was 31. And these patients were fairly recently diagnosed with peripartum cardiomyopathy. The majority of them were diagnosed very close to their peripartum cardiomyopathy diagnosis. Interesting as well, their Intermax profile of these patients was really high. So Intermax profile 1, that crashing, burning patient, 38% of those 16 patients fell into that category. And another 44% of that 16 patients, so 7 other patients fell into the Intermax category too. So these patients were very, very sick upon initial presentation. And several of them required additional mechanical circulatory support devices like a balloon pump, other types of ventricular assist device support, and even ECMO as well. So those were the things that I found the most interesting, was the young age of these patients, the time since the peripartum cardiomyopathy diagnosis, and the severity of their intermax profile upon initial presentation as well. When they looked at these patients, the large majority of them at the time of LVAD placement were considered to be a possible bridge to transplant, 11 out of 16 or 69%. The majority of these patients at the time, since this was between 2011 and 2018, were implanted with a HeartWare HVAD device, with smaller numbers with HeartMate 2 and HeartMate 3. Although I suspect that if you were to look at the data now, since the HVAD is no longer on the market, you would see a much higher number of HeartMate 3 pumps as well. Interestingly as well, the patients largely recovered. There were only, in the follow-up data of 15 patients, there were 2 patients that had mortality events while on VAD support, but the rest of them either were transplanted, underwent ongoing support, or were able to be weaned. And the most important complication to be noted with the device was a driveline infection, with 10 out of the 15 patients having a driveline infection. Furthermore, they looked at, in this study from the Artificial Organs Journal, patients from both Germany and the Middle East with long-term outcomes in patients with peripartum cardiomyopathy receiving LVADs. Again, very small numbers of patients. There were only 12 patients that were included in this study. But again, interestingly enough, the intermax profile of these patients were quite high. So very, very sick upon initial presentation. The majority of these patients required some degree of temporary MCS prior to LVAD implementation. And again, the time from the peripartum cardiomyopathy diagnosis to LVAD implantation was quite low, less than 1 month in 7 of those 12 patients. This group also reflected a higher number of HVAD patients at that time. And again, as far as complications, the most common complication that these patients had was a driveline infection as well. But the important thing in terms of outcomes that I took away from this was that the patients ultimately, the largest majority of them did survive. They either were transplanted, 4 out of the patients were transplanted, another third recovered, and 2/3 of those patients were alive after going through this cardiogenic shock, severe intermax 1 or 2 experience, probably large part related to combination of age, appropriate ICU care, and such. But I think that's an important piece to take away from this, that it is possible or feasible in certain scenarios to consider a durable device during this type of time period after a bridge from a temporary type of device. There is very limited data on durable devices in pregnancy. As you can see on the right side of your screen here, a lot of the case reports are quite old. There's 2 from 2011, 1 from 2017, and 1 from 2019, and then the one on your left here is from the 2021. But as more and more patients continue to develop heart failure, I think this will become a more and more important topic to follow up on. Certainly the maternal and fetal risks need to be considered and need to be determined whether that can be minimized so that childbearing women could have a successful delivery while being supported with an LVAD device. So the key takeaways, as I mentioned, from these limited case series are that many of these patients are younger, require temporary MCS as a bridge to further decision-making. This really mirrors the trend that we've seen in other non-peripartum cardiomyopathy or non-pregnant shock patients. These patients are often sicker upon presentation, as I mentioned, higher intermax classes. The limited case series from Europe and the Middle East in 2022 suggests a trend towards the likelihood of needing transplant being higher, but again, these are very small numbers, 12 and 16 patients in the 2 studies that I shared with you. So as a result of that limited data to guide our decision-making, the multidisciplinary consensus at each center is key. So now I'll switch to talking about pregnancy post-heart transplant, again, an area where it is quite high risk and limited data. But this article that came out from Zurich Heart Failure in 2020 looked at survey results from 122 transplant healthcare team members and really explored attitudes, practices, and center policies surrounding pregnancy and heart transplant recipients. Notably, from that survey result, 67% of the providers thought that pregnancy could be feasible for select women, whereas 31% of those healthcare team members that were surveyed suggested that pregnancy should be avoided in all post-heart transplant recipients. And then a very small minority, 2% of those healthcare team members thought that pregnancy could be feasible for all post-transplant heart transplant recipients. When surveyed further about what the most important contraindications to pregnancy in a post-transplant patient would be, more commonly seen were things like a history of rejection, reduced LV function, donor-specific antibody presence, cardiovascular allograft vasculopathy, non-compliance, and then a history of peripartum cardiomyopathy pre-transplant came up as reasons for why a patient post-heart transplant contraindicated pregnancy would be contraindicated. Here also, the providers that were surveyed commented on what the most optimal immunosuppression regimen that would be recommended during pregnancy would be. By far and away, most people thought calcineurin inhibition alone should be considered, but much smaller numbers would consider a combination of calcineurin inhibition plus other immunosuppression. This is data from the IACGLT 2010 guideline recommendations, which was the last time that pregnancy post-heart transplant was addressed in those guidelines. You can see on the left side of your screen the medication classes, so antimetabolites, not recommended, just should be discontinued in pregnancy, ideally before pregnancy as well. The mammalian target of rapamycin or mTOR inhibition are large concerns regarding wound healing. And definitely there should be a discussion about discontinuation if a C-section is planned. And then we have calcineurin inhibition and corticosteroids, which could be continued in pregnancy with a level of evidence C from the prior FDA categories. The IACGLT recommends a baseline assessment of graft function before conception with an EKG, an echo, and a coronary angiogram, if not performed within the previous 6 months, and a right heart catheterization and a biopsy may also be considered. I put this in to just really highlight the IACGLT recommendations, which are from 2010, but highlight the multidisciplinary team, highlight individualization for each heart transplant recipient, risk of acute rejection and infection needs to be considered. If graft function and significant CAV are present, then the patients need to be really counseled on the risks of pregnancy, and pregnancy should be discouraged. Pregnancy in a heart transplant patient should generally not be attempted sooner than 1 year post-operatively. And frequent surveillance is really important to, with respect to not only graft function, but also end organ function as well. This is from the American Society of Transplant, saying that as a consensus statement, transplant recipients considering pregnancy should have had no rejection in the last year, adequate and stable graft function, and stably dosed immunosuppression. But as you can see, it leaves a lot there open to interpretation. Some of the things that we do here are preconception assessment for those patients post-transplant who are interested in family expansion. So we do the patient and partner HLA testing. We make appropriate pharmacotherapy adjustments prior to consideration of pregnancy. We will do preconception surveillance testing, discussion with our key medical stakeholders and the multidisciplinary team, and an exploration of alternate methods of family planning as well. This is the largest registry of heart transplant recipients who have had pregnancies. This came out from the team at Vanderbilt back in 2020, looked at 157 patients from the voluntary transplant pregnancy registry. Of those 157 pregnancies, 106 deliveries were reported. Notably, 46% of these pregnancies were unplanned. 23% of those patients ended up with preeclampsia. And notably, 13% of these patients had severe rejection in the interpartum and 10% in the 3-month postpartum period, with a median time to rejection of 7.2 weeks. So the key takeaways from this for me were really counseling all of our patients who are female post-transplant of childbearing age about their family planning thoughts, and being able to have those shared decision-making conversations are really, really important to prevent many of these pregnancy complications or outcome related complications as well. So again, limited recommendations, guidelines, and consensus statements, significant variability in practice pattern and center-specific protocols, probably related to the center-specific familiarity with caring for patients that are this complex. But with improvements in post-transplant care, I anticipate this to be an issue that we'll need to be prepared to address safely as more women of reproductive age undergo transplant and live longer post-transplant as well. So let's talk in our waning few minutes about peripartum considerations for labor and delivery. We really have to look at the intersection between the patient, the disease, and the pregnancy, looking at the patient's volume status, what are their vital signs, what is their body positioning, what is the disease, what is their lesion type, what is their lesion severity, what is their ventricular function. And with respect to the pregnancy, what is the gestational age, what is the fetal size, what kind of anesthesia do we need to consider? What mode of delivery do we feel like is going to be the safest? It is recommended to consider an induction of labor at 39 weeks for all patients with a history of cardiac disease. Vaginal delivery is preferred for most patients, with cesarean delivery reserved for obstetric indications, and really important to have a written care and delivery plan with a multidisciplinary team. I put in here from our colleagues in ACHD and MFM, Dr. Afshar and Mary Canobio, the sample delivery plan checklist that they published last year, where it goes through the patient risk category, what the patient is at risk for, what are the admission considerations for the patient, the delivery management, endocarditis prophylaxis if needed, and even highlights recovery, postpartum, and discharge planning. And I think having this comprehensive plan can be really helpful to make sure that everybody's on the same page, especially if there are changes in team members during the patient's admission. This can be a really great reference to have available. Similarly, our colleagues in anesthesiology and OB anesthesiology have defined ways that they can help support these patients and help to ensure safe outcome for these patients. So defining a maternal level of care based on the level of illness of patients that can be treated. So going from a birth center where there's really no anesthesia staffing to a level 4 center where They can be equipped to take care of modified WHO class 1, 2, 3, or 4 patients with somebody who has fellowship experience in obstetric anesthesia present physically at all times. Again, doing a pre-delivery consultation with anesthesia, specific considerations for labor, delivery, and the postpartum time frame. Having those written out and listed can be really beneficial to ensuring the safest mode of delivery for these patients as well. And thinking about some of the side effects of the medications that are commonly used in obstetrics with respect to uterotonic agents or uterine relaxation agents is really important as well. When we think about other peripartum considerations, we have to be vigilant for red flag signs and symptoms. So things like chest pain, dyspnea, orthopnea, cough, edema, tachycardia, non-vagal syncope, headaches, visual changes, and hypo or hypertension are really important to pay attention to and act upon in the peripartum time period. I want to go back for just a minute and just highlight again these 6 critical time periods across the reproductive continuum that we've talked about in these very vulnerable patients, and the importance of identifying these issues early on, trying to optimize them as early as possible, and then following them with close surveillance over the long-term time period can really help with preventing complications over the long term as well. Because when we put the disorders of the cardiovascular system together with adverse pregnancy outcomes, together with pre-existing risk factors for cardiovascular disease, we have an elevated lifetime risk of cardiovascular disease for these women, and that's not insignificant. Notably, there remain disparities in women's health over the course of a woman's lifespan. This spans not only the heart failure population, but also hypertension, hyperlipidemia, anticoagulation, even post-STEMI care. And this really needs to be a call to action for all of us to be aware of these gaps in care and to be able to address those effectively when we're aware of those disparities in care. Some of the future areas for research considerations or study in the management of advanced heart failure in women span things from hemodynamic instability to biomarker derangements to frailty to waitlisting prior to heart transplant to temporary MCS and anticoagulation strategies and LVADs to even referral and allocation of advanced therapy indications. So, there's a number of areas where we have room to improve and room to learn more on the differences between care for females versus males. Briefly, wanted to highlight our cardio-obstetrics program that we have here, which is certainly collaborative and multidisciplinary in nature. We've really been working over the last several months and years to make this an experience where patients can have access to all of our expert care in a timely fashion and try to coordinate things for the patient to make it much easier from a continuity of care standpoint as well. We also, on the cardiac side, have a strong interest in helping train our fellows. So we have been focusing on increasing opportunities for our fellows in training, whether that's clinically related, whether that's research related, or even sharing our experiences with many of the patients that have been treated in our CCU very recently with peripartum cardiomyopathy or cardiogenic shock within that time frame. And I'll end with thanking our collaborators with the cardio-obstetrics program, with cardiology, and definitely my colleagues in the Cardiomyopathy Center right now who have been helping out over time to make sure that the little one that I'm expecting stays cooking inside. So really appreciate everyone's time today. In the interest of time, I'll direct questions to my email address. So we can definitely answer anything that comes up after that. Thank you so much.
Thanks, Megan. That was a really excellent talk. We really appreciate taking the time to talk to us today.
Thank you.
Bye, Megan. Thanks so much.
Thanks.